I think the attendee entrance waiting room has slowed down now, so I think we'll kick it off. Good morning, everyone. My name is Stephanie Thompson. I'm the Manager of Advocacy here at the Mental Health Lived Experience Peak Queensland. Just want to welcome everyone here today, but I'll starting the traditional owners of the lands on which we're meeting today. Here we're presenting from the Brisbane region, so the Yagara and Turrbal people. And I just want to thank the elders past, present and emerging for their wisdom and survivorship. I also want to acknowledge that First Nations people have a unique experience of stigma and discrimination, particularly when it comes to mental health challenges. And as most of you are aware, there is quite a bit of intergenerational social disadvantage and marginalisation of the community. But thank you for coming today. This week is Mental Health Week, and we really wanted to take this opportunity to bring people together and explore how human rights frameworks can transform the mental health system. With that, I also want to take a moment to acknowledge and thank those with lived and living experience of mental health challenges. We truly recognise the strength and resilience and leadership that expertise in this space brings to shaping systems and services. And we also recognise that the stigma and discrimination is too often used to silence these voices. So we are truly committed to ensuring that lived expertise and lived experience is elevated in our work. Just a bit of housekeeping, just letting you know that this webinar will be recorded. All participants will be de-identified in the recording, and further consent will be sought if this webinar is used for further materials by the Mental Health Lived Experience Peak. We'll begin with a presentation from Simon Katterl, our CEO at MHLEPQ, basically on the human rights in the mental health sector and the opportunities to strengthen and embed these frameworks, not only as inspiration, but inspiration for reform, but also obligations to law. And then we'll have our panel discussion with Scott James, Ayden Riethmuller, Simon Mann, and Julian Torreas, sorry if I butchered anyone's names, and then Eloise Waite, our engagement lead, will talk about some of the work that we've been doing here at MHLEPQ. And then finally, we'll use Slido. I'll make sure I put all of the details in the meeting chat to take questions from the audience. So thank you for joining us again today. And with that, I'll pass on to Simon. Thanks.
Wonderful. Thanks so much for that, Stephanie, and for opening up this presentation. And thanks to everyone who's arrived here, as well as our speakers. I'm going to jump straight into the presentation. So you'll just have to bear with me as I get that going. Right. Here we go. So, oh, sorry, bear with me. Anybody have an idea? What was that, sorry?
Hi there, my name's Simon Katterl. I use he, him pronouns, and I'm the CEO of Mental Health Lived Experience Peak Queensland, the peak body for people with mental health issues across Queensland. Now I'm here today because it's Mental Health Week and we've just provided a webinar. It's called Connection, Human Rights and Reality. It's talking about the human rights challenges and opportunities we have in mental health and Queensland. So let's unpack it together now. But I want to begin by acknowledging the traditional owners of the lands that we're on today, the Yagara and Turrbal people. I want to pay my respects to elders past and present, any First Nations members joining in the webinar today, and affirm that sovereignty was never ceded. And when we think about human rights today and in this discussion, it's important that we ensure that advancing collective self-determination and the cultural rights of First Nations people is at the centre of any mental health advocacy or reform we do. So the webinar today is really about human rights. It explores human rights, what they are, the problems that we're having with them, the application of them to real life scenario and real life policies, and then the opportunities that they create for a better system for everyone. So what are they? What are human rights? Let's unpack that. We could spend a long time unpacking this, and many people have written many PhDs about it. But there's some kind of simple buckets that we can put human rights into. So one bucket of understanding is that they're moral expressions of our inherent worth. They're legal checks on the arbitrary use of power. And they're also thinking tools to help us rethink problems and then rethink new solutions. It's really the last two of those three that'll be the focus for the presentation today. That they're legal checks on power that give rights, and that they're ways for us to approach some of the key problems we face in the mental health system in a new light. This session isn't about international law, but you wouldn't be able to do a session like this without touching on international law. Australia has signed up to a whole range of international treaties and conventions, most notably the Convention on the Rights of Persons with Disability, the UN Declaration on the Rights of Indigenous Peoples, and the Convention Against Torture. These are some of the key international treaties or declarations that Australia have had that do have a direct impact on mental health. And if we're going to take that seriously, then really we're going to have a radically different mental health system. It'll be a rights-based future where we actively address the social determinants of mental health. It'll be a rights-based future where services are provided on the basis of free and informed consent. And it'll be a future where people access those services based on free and informed consent because they're culturally responsive, they meet people's individual needs, and they're located in the communities where people live and play. But in Australia, international human rights aren't directly enforceable until they're domesticated into state or Commonwealth law. So that's why we're lucky in Queensland that we're one of 3 jurisdictions that have passed standalone human rights legislation. That's the Queensland Human Rights Act. So that act, it does many things. The first thing it does is it gets human rights and it legislates 23 of them. That's an important first step. It then outlines the different roles. So it gives Parliament a role of seeking to make laws compatible with human rights. They don't always live up to it though. It gives courts the role of interpreting existing laws in ways that are most compatible with human rights. So it takes existing mental health laws and seeks to interpret those in ways most compatible with human rights. It gives public entities, which includes mental health services or government, responsibilities to comply with human rights when making decisions. Now, just make a bit of a sidestep. People have justifiable concerns about the role of or power of Parliament to override human rights laws. And we saw that in youth justice laws recently. This is a real shortcoming, but when we talk about the things we're going to discuss today, it all relates to responsibilities on public entities who must properly consider and comply with human rights. And they can't overrule human rights laws unless they can get Parliament to draft laws in their favour. And that's a pretty rare circumstance. So I don't want to let pessimism take over the real opportunities we have when we talk about the responsibilities on public entities to properly consider and comply with human rights. So you've heard the properly consider and comply bit. That's kind of the crux of this presentation. Whenever a public entity makes a decision that can impact human rights, it must properly consider and comply with the relevant rights. So properly consider means they've got to be able to show they considered specific rights at the times that they made decisions. So not just general human rights. And comply means sometimes you're allowed to limit human rights to balance them against other rights, but they need to be justified according to clear criteria. That's it. That's the key duty. Public entities must properly consider and comply with human rights. And it's a simple duty, but it applies to the whole system and a really diverse array of decisions. So for example, it applies to the decisions that a clinician makes with a consumer on a mental health ward, but it also applies all the way up to the level of government and departments when they decide what services to fund and how they want to fund them. So there's all of those decisions can impact on human rights, so public entities in all of those circumstances need to properly consider and comply with them. But if you work in the system or you've used the system, you realise we've got a problem. Our evidence and the evidence of the independent review into the Human Rights Act in Queensland has found that we haven't properly developed a human rights culture. And that's a missed opportunity. It's a missed opportunity in the past, but that's not it. We've still got an opportunity in front of us, and that's why we're doing this presentation here today. Part of the challenge we have is that human rights are not thought of enough at the start of government decision-making processes. So it's often when we fail to think about human rights early that we actually end up having to hastily make fixes later. Let's use a concrete example. So, imagine you're not like me and you're not completely useless with your hands. You're a builder, and we're talking about disability accessible design. So, builders or architects, they'll sometimes cut corners and don't think about disability when they design a building they're designing. That does harm, but it also costs later, where they have to make many stopgap changes, revisions, they have to put safety nets in and retrofits, and it's ultimately to fix a building that was never designed for people with disability. But if they thought about disability accessibility from the start, and that's increasing the expectation within the community anyway, they'd have these features built in. That does two things. It prevents harm to people with disability, but it also saves everyone time and money. And this metaphor or analogy applies just as well, I hope anyway, to the mental health system. Look, this mental health system we've inherited is not one grounded in human rights. It couldn't be. It's 5 years old. Our mental health system is hundreds of years old. So the way we actually conceptualize the relationship between mental health and human rights, it's kind of broken. We see it as a battle between health and human rights, a battle between safety and human rights, and that battle, it often costs money and it causes profound harm. But we can do it differently. If we think about human rights earlier, we find that dignity is an indispensable part of good mental health care, that safety is something that's found together, and the evidence shows that. Ultimately, funding goes to a diverse range of services, and our community is seen as a holding point for good mental health and dignity, something that we support together. So when we take a step back and think about human rights from the start, there's many benefits to the system. The quality and safety of our services improve. They're more equitable and responsive to people's needs. Lived experience leadership sits at the heart of decision making. Coercion is being eliminated, as it's being done elsewhere. The workforce is better supported, and we reconceptualize advocacy and really problematic and tricky concepts like risk. Possibly by this point you're jumping out of your skin with excitement, but also the question, how do we put this into practice? So let's dive into that now. So let's take a practical example. So Sarah's an Aboriginal woman who's connected to her family and culture, but she's detained under the Mental Health Act for compulsory treatment. She wants her family to be part of the decision-making process, but she's told it's not possible. The ward's too busy and so are the doctors. This alienates Sarah and ultimately causes more harm. Harm is reason enough really to be concerned here, but let's ask the question, what do human rights laws have to say about this? So in making the decision, the Public Mental Health Service would need to show that they'd properly considered Aboriginal cultural rights and equality rights. These rights are being negatively impacted by the service's decision. If there's no evidence that they considered these rights when they made a decision, they've potentially breached the law. If we find that the reasons aren't legitimate for why they limited these rights, and they don't sound like particularly good reasons, then they could be found to have breached the law as well. So it's a sad story, but not one we haven't heard before. There's lots of things that Sarah could do. Sarah could make a complaint to the Queensland Human Rights Commission, or she could eventually take her claim to the Queensland Civil and Administrative Tribunal or a high court. So let's take another really practical example, and instead let's look at some current practice or policies that we find within a health service. So we know here in Queensland that some services use locked wards and others don't. And the justification they make is that they're looking to keep people safe to themselves or from other people, or to other people. So this process of locking a ward, it engages human rights. That happens to be section 58, which relates to the duty to properly consider and comply with human rights. That's the one we keep banging on about. It engages the right to equality that we've already spoken about. It engages the right to privacy and reputation. It engages the right to liberty and security of persons. It actually engages a whole range of further rights, but those are three that are deeply engaged through the use of locked wards. So as soon as we know those rights are engaged, we know that this is a human rights issue that needs to be thought through really clearly. So then the question goes, well, firstly, is there evidence that they've considered these rights? If not, in the development of this policy or decision, if not, then they've potentially breached the law. And then we'll go to that other question of, okay, they've limited it, but can they justify that the limitation is reasonable? And in doing that, there's a whole range of questions that the law provides, but I've tried to apply that in 3 kind of dot point scenarios or points of evidence that we have on this topic. So the first is that we know these rights are really important that are being limited. So the rights that are being quite significantly restricted will compare being locked in a psych ward is a significantly greater restriction on your rights than being kept in lockdown for the same period of time. Because, for example, that's not done on a discriminatory basis based on an arbitrary attribute like mental health or disability. There's limited evidence that locked wards actually work. So we know that some of the evidence is not particularly strong that it does keep people safer or not. And so if you're going to restrict human rights to a great degree, you need to have a great degree of evidence. But we know that's not the case either. And then we've got the fact that there actually are less restrictive alternatives. And how do we know that? Well, we know that because some services are utilising less restrictive alternatives. We have unlocked wards across the country, including in Queensland. So there's 3 evidence points here that make it hard to justify the use of locked wards. And so here's another example of where we can make change and drive improvements through applying the Human Rights Act to existing practices that are happening here in Queensland. Okay, so we've had a few examples here. We've had the practical example with Sarah about how human rights could enhance cultural safety in that interaction. We've then got an example of reviewing current practice, like around locked wards, and how the Human Rights Act drives improvement there. Now let's take a forward-looking example about, well, you want to build something new. And in this case, we're thinking about, well, we want to design a new mental health ward where people are safe, find healing, and want to return. And we haven't got a name yet, and maybe in the spirit of IKEA, we'll call it the Fladlost unit. I'm regretting it even as I look at it now, because I think about the fact that I've probably had some of my greatest breakdowns trying to put IKEA furniture together. But we'll leave that to one side. So when you're applying the Human Rights Act to a forward-looking process, you can really kind of break it down to 3 steps. The first is clarifying, well, what's the purpose of what you're trying to achieve here? So you're trying to build a new mental health ward to support people with mental distress. You might say, and you want to keep people safe, enable healing, and make sure they want to return. Then you've got to figure out, well, what rights are engaged or potentially limited by doing that? And when you do that, it's often useful to think about, well, what would a status quo mental health inpatient unit engage and limit? So we know with mental health wards or environments generally, they often limit the right to equality. For example, they're locked wards as a policy that's engages the right to equality because that doesn't happen in many other wards where you're not diagnosed with a mental health issue. Humane treatment when deprived of liberty. So sometimes you might be detained within a ward or kept in a high dependency unit, and the conditions in there are so poor. So it's an inhumane treatment when you're already being locked within a ward. And sometimes your right to culture is limited, as we saw with Sarah. So we've kind of seen a combination of the kinds of stories come together already. So we know the existing status quo already limits these rights. And if you take my sort of loose arguments from the last couple of slides, it unjustifiably limits those rights. So what does that do? It says we've got work to do. That's good. We're at the start of the process. We're designing the new ward. So step 3, start to make decisions that are more, it prompts you, it demands you to make decisions that are more rights compatible. So you find alternatives to the use of locked wards. They're out there. They're out there in Queensland. They're out there in Australia. We've got plenty of examples. It says we've got to find reasonable alternatives to the use of seclusion rooms. We already know that there's services across the country that haven't had a seclusion episode in 2 years. And they use early support, calm down spaces, peer-led response, staff training, and a mission-driven approach to eliminating seclusion and restraint. And there's often better outcomes for staff safety too. And then it says we need to find alternatives to the use of risk assessments, because we know those often lead to false positives, where someone's deemed high risk and therefore unjustifiably has their rights limited. So, for example, using things like shared safety planning. Now, you might say, well, we could do all of those things without human rights. That's true, but human rights says you have to try to do those things. And so if you're not seeing those things done, the Human Rights Act is a good way to prompt decision makers to come to the table to say the status quo is limiting rights. For us to act lawfully, we need to think about reasonable, less restrictive alternatives, like the Fradelost mental health inpatient unit. So then let's think about opportunities, both the short term and then the things that we can do together. So many opportunities. Really, probably a starting point is law and policy reform. We've got a Mental Health Act that's coming up to 10 years old now, and there's work to be done there to align it with some of the best practice across the country. For example, legislating an aim to eliminate seclusion and restraint, and then creating a broader plan to eliminate the use of force from the mental health system. Service reform is key. So reforming, well, I guess how we make decisions of what kinds of services are funded and then how they're funded. We need to embed clear statewide policies around cultural safety, gender responsive care, and create local and statewide plans to eliminate coercion. Individual action is going to be key too, and that might come from you as an individual change maker working within the system to pick up and use human rights laws, or it might be someone who's accessed it, who wants to use their experience to change it and make it better for someone else. I guess the final message is we're really here to help. We're here to help you if you want to help change the system. So we know there's a couple of barriers in place and really a couple of opportunities. So we know there's no statewide training that especially focuses on the Human Rights Act and how to embed that across the system. That's a gap. We'd love to work with someone to fix it. We have information to our members, and we'll put the links in the notes below this video that talks directly about how you can use your human rights under the Human Rights Act to drive change and to get accountability for your own experiences. And for government, we want to be seen as thinking partners to help you to think about human rights earlier in the decision-making process, so we don't have to talk about harm after that decision-making has taken place. Those are win-win examples that we're really excited to share in. Take care. Thank you.
So we're back to the panel, our superstar panel. Thanks everyone for your flexibility there. So I might open it. I don't know where I froze. I'm sure it was a really ugly face that I had. That is my resting face. But where do you see human rights coming up in the work that you're doing? So I might open that up to anyone. So you've all worked in the space or in various capacities and been around the space. Where do you see human rights coming up in your work? Scott, I'm gonna throw you under the bus. Why don't you give it a go?
Sure, no worries. I think we're all being very polite. Excuse me. Look, obviously, having rights in the titles across the board, it's something that we need to consider with everything that we're doing and all decisions that we're making. I do want to, I suppose, I'll make a couple of points. Being, if we think about when the Human Rights Act came into effect, 2019, which is still 3 years after the Mental Health Act. And during that time, government have to assess all their legislations to make sure that they met those requirements. And there were certainly tweaks done and some changes done to bits and pieces of legislation or tacked on to the end. We've moved also further than that. So I see it as being actually an evolution as we keep moving forward. So we've got chief psychiatrist policies, which are statutory policies. And previously they were assessed, yes, they met they met the requirements of the Human Rights Act, but we've moved through that, and thanks to the lived experience workforce and lived experience members who have looked at those policies saying, well, actually, we need to embed human rights within those policies. So I sort of see that as being a bit of a shift. But we also have hospital and health services have to do their impact assessments of human rights when they're dealing with stuff. And I know some of the rights advisors that I support are having to do those assessments in any change that they're making. So yeah, look, it's part of our everyday work.
Yeah, and I mean, it's you get to see the inside of a system in a very unique way in the work that you're doing, Scott. So thank you for highlighting that and for doing the work you're doing. Who else is keen to jump in? Julian.
Yeah, for me as a peer worker, I mean, it's probably one of the human rights thing for me is about advocacy, and I don't mean just talking about stuff. I mean advocacy that can be actually measured, has a real outcome. We don't just say we're going to say this on your behalf or speak about it on your behalf because they're just words. It's like advocacy that really has a measurable outcome. And it's not we just put a tick box into sim or whatever system to say, yeah, we had a chat about advocacy. That's not really helping anybody really. It's not even a band-aid solution. It's a bit of a fluff piece. It needs to be something that can actually be measured.
Yeah, I hear you, Julian, and I think often we can the discussions around human rights can be kind of really broad and esoteric. I think actually they're really practical tools that I know peer workers pick up and use every day. Any other comrades keen to provide their expertise?
I'll jump in, Simon.
Please.
I guess coming from a nurse, obviously, and I'm an educator at the moment, and for me, it really comes into molding the new curriculums and what we actually teach the next generation of practitioners, because as much as there are significant harms occurring right now, I do see shifts happening intergenerationally as well, both in terms of obviously how much we talk about mental health broadly, but then how we actually look after each other and speak to each other about it too. So part of my recent work and goal has been to shift the curriculum for our nurses, at least, who tend to be at the forefront of enacting a lot of the violations of human rights, sadly, and really empowering them to recognize what the human rights are and understand their obligations regarding those human rights. And that's something that had been lost on me even as a clinician. I mean, working in the space, it was not something that was at the forefront of our minds. And that's terrifying in hindsight now, that it wasn't. But structurally and clinically, it wasn't integrated into what we do at all, sadly. And I expect that that's going to be, if it hasn't already, an area of significant improvement in terms of accountability, which we'll talk about later.
Yeah. Well, sneak peek into our later discussion then from Ayden. And absolutely, I think that speaks to the point that the system we've inherited was not founded on human rights. So there's, that's not the end of the conversation. That's the start of some good work. I might pass to Stephen. Stephen, did you have anything on that first question? But also, I'm keen to get your sense on a whole range of rights, but including Aboriginal cultural rights is something that people often don't understand. Do you see any intersection there in the mental health or social and emotional well-being system?
Yeah, absolutely. Thank you, Simon and panelists. I think that for the First Nations community, what we see and have observed over the last 50, 60 years particularly, is a lack of culturally appropriate services. And so why is that important? Well, there's a right to practice our culture, but it's also about self-determination. So, and when we talk about self-determination, it's not as much as we're talking about the rights of the individual, but rather the rights of a community. So in that 50, 60 years, the Aboriginal and Torres Strait Islander community, the First Nations community, have been working away in various fields in the health sector, and they have developed expertise at servicing their own community. They have developed best practice and even communities of practice that deliver the solutions that we know are needed in First Nations communities. Now, the issue is that, from the impacts of colonisation, we continue to experience trauma in the form that we are forced to compromise who we are every day. And that trauma, of course, creates illness, sickness, and disease. So we compromise who we are to satisfy people that are in positions of power and influence. And that is that First Nations people are very often not in these positions to make decisions, are not in the positions to direct programs or funding or budgets. And so often what happens is, in fact, we're under-resourced, and the staff or the organisations that are providing services often cop the blame for the inadequate service delivery, and not the decision makers, not bureaucracy, or even the legislation or policies of the day. And so we kind of get stuck, between two hard places and a lot of frustration and stress is created when we're trying to create a safe space and create a space that is thriving for the Aboriginal Torres Strait Islander community, but often with our hands tied. So, it is all about this stuff, about having early consultation, engagement, the whole concept of free, prior, informed consent. And, so the big battle for us, I feel, is that we've got to get into these positions where we can make decisions, and we need to be included, well, not just included in those consultations, but really be able to impact the work that's in front of us.
Thanks, Stephen. And it's such a rich account of how broader government policy that doesn't consider human rights, self-determination, Aboriginal cultural rights across so many areas is what creates the distress. And then also the health and mental health systems that people interact with, they haven't considered those, or it's not necessarily the case that they've properly considered those rights when they design and fund those systems, which puts staff in a really difficult position where they can't meet the needs working within the parameters that they have. And so there's and that's not to say that services and staff couldn't do better. We've seen plenty of instances of that, but you're really highlighting there that the Human Rights Act is about early decision making, thinking early, and applying human rights early, so we create better outcomes later. We've got a next question, which is, and just a reminder for folks that use the Slido if you want to get questions in there. I'm going to be diverting and double checking the questions in a second, but please pop your questions in there, and we'll make sure we get responses back to your questions if we don't get to them here today. So for the panelists, and please jump in at your own leisure, what do you see as the biggest issues around human rights in your space? And I suppose as part of that, I'm keen to understand, so what are those issues, but how did we come to be at that place from your perspective?
Well, I can jump straight in and simply say money, 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 money. It's resources, straight up and down resources, capacity, whatever you want to call it. That's where it comes in, because as Stephen was saying about trading off certain things to appease certain things, there's also an aspect of just services, whether it be big hospitals, small service providers. There's always something to be traded off to get somebody some form of care, even if it's not great care, which also can actually lead to harming people. So it's a resources thing, and ultimately that boils down to being properly funded. And if we do things properly the first way around, with the human rights at the forefront, it's actually it would be more efficient, because as you were saying earlier, we wouldn't be putting stopgaps in, we wouldn't have to be in repair jobs, we wouldn't have to be rescuing a service or whatever it is, or shutting it down for a period of time to do an assessment on it. Whatever, they're all massive inefficiencies. Whereas if we funded it from the start properly with the human rights at the forefront, like Simon was saying, those things would maybe not completely disappear, because you're never going to have a perfect system, but would be greatly reduced, and it would be better outcomes in the long run, even in the short run, for everybody.
Yeah, Julian, I think that highlights so much of it, isn't it? So the resourcing and then the way we use that resourcing remains, and that we often don't think about funding and human rights as being that connected, but really that's probably one of the biggest levers and the biggest areas where you can make the biggest difference. So where does the money go? To what kinds of services? And then when it goes to those services, is it articulating how those human rights standards need to be embedded? Anyone else on that question?
I would also quickly like to add funding models about how the money is distributed. Let's move away from tendering processes, because we all know stuff about tendering processes, how they can be skewed to big boys and good service providers that are small who can't go through those processes. So we need a new funding model.
Yeah, absolutely. I hear you, and I think there's a long conversation about competitive tendering. But and we should ask the question whether that's helping or harming when it comes to human rights outcomes. Absolutely. Anyone else on that question though? What are the biggest issues you're seeing?
I suppose I just want to make the point, enduring that links between rights and recovery. And when we're seeing good engagement for individuals across the board, whether it be patients, clinicians, or consumers, and part of that is understanding what statements of what works for you, and they talk within the Act, Mental Health Act, around views, wishes, and preferences, so that you're going with these statements to start negotiating treatment, what that might look like, and being clear around your expectations. So using those rights and understanding those rights, whether it be human rights or rights under the Mental Health Act, to get the outcomes that you're looking for. And just how do we get there? For me, it's around we all can play a role in talking about rights, and the statement of rights is a basic sort of a pamphlet that or booklet that can be used to guide those discussions around those expectations, and we can all do that. So just that links between rights and recovery.
Yeah, absolutely. And for those not aware of it, I think there's the CHIME model of recovery, and I'm pretty sure autonomy and rights is embedded in there somewhere. But Stephen or Ayden, Stephen.
I guess I would just jump in around some of the biggest issues that have always sort of plagued my practice as a nurse have been, on hindsight now, that the permissory nature of the Mental Health Act itself. So I've gone over and over this time and time again. I mean, it's a relatively new act, but it also was revised in a similar-ish timeframe from the 2000 Act. But even so, the 2016 Act, it time and time again through it gives opportunities, many opportunities and excuses to clinicians, services, providers to breach human rights. It is, in my view, as a clinician, it is the enabler of human rights breaches. Because what would happen is, if the Act didn't exist, if we didn't have a legislation allowing doctors to authorize seclusion, for example, or restraining people or whatever, what have you, it would be a crime. It would just be captured under the criminal code. So this is the thing. The Act, what was meant to be brought in to protect people, arguably, maybe that's a bit too highfalutin, but arguably was meant to be brought in to protect people from harmful practices. and to put some regulations and boundaries on what can be done still is the primary enabling tool for what bad happens. So either, I take both stances. I know we've got beautiful people who work in both of these camps of abolition and reform, and I'm not a fence sitter, but I support both teams. I think any change is good change. Let's make something happen. And I think, Simon, we have talked about this in passing, that the Mental Health Act itself is probably due for a refresher, and that might be an opportunity for some significant change to take out those permissory statements like may. I take as an example, just as an aside, because it's a really important example. I think there is a section in there about supported decision making, which is, I think, beautiful. It should be the gold standard. It should be the only way we do things. Yet the wording of that particular provision says the person may be supported by another person, to make their decisions. So in other words, there's no obligation on the service provider or clinician to get someone else, a family member, a friend, a support person, a nominated support person, to ensure that the person is supported in retaining their capacity to make those decisions. There's no obligation. Basically, if you go in and you're deemed incapacitous, you're ruled out, and they have free game, which is for me that's devastating.
Yeah, yeah, I mean, these are great points there, and I jump back to the earlier point, which is, the laws we have you can argue they're there to regulate or minimize the harm around compulsory treatment, but they create the permission structure, as you say, to do it. And the example that you provide around seclusion and restraint, what would happen if the next mental health wards built just didn't have seclusion rooms? We know that's possible because we know that the services in Queensland and around Australia that just don't use seclusion. So there is a less restrictive option available. So it's that it needs to be flipped, which is that when the next ward is built or refurbished, can they justify keeping that seclusion room? Is one of the ways that we can flip some of those answers. Stephen, is there anything you wanted to add there about some of the key issues you're seeing in the space?
Yeah, so mine's kind of a big or broad kind of issue, and I try to also address everything that comes across in Slido or in the Teams chat, so that I'm not just talking to First Nations specifically, but one thing that does come across in my space is that there is an assumption that all things are equal. So given that, it's sort of this economic approach of all things being equal, we will apply this, or we will create this program, or this money should be enough, all things being equal. But the hard reality is that things aren't equal, right? There are First Nations communities that, for all intents and purposes, are disaster zones. And what we need to do is work with individuals to assess their need and the level of support that they require. The same can be said around communities, within the disability space or the LGBTIQA+ space. There are certain segmentations that we know the demographics, that the sort of environmental context is not equal for them as it may be for most Australians. And so we need to really apply this lens or it's the old, patient-centric or people-centric approach to care again.
Absolutely, Stephen. And, there's that, putting the person at the center of the decision-making process is a kind of crucial part of often when of public policy. And often when systems are set up, we often think about the system rather than the person that the system is meant to serve, which can produce the kinds of failures and challenges that we see. Okay, so we've kind of, and this I noticed one of the Slido questions is kind of related to this. But one of the questions, we've only got 2 more pre-prepared questions, and we'll jump over to the Slido. But does anyone want to dive in on this question, which is how do accountability mechanisms? So we have some accountability mechanisms here in Queensland. They're the Queensland Human Rights Commission. People can make a complaint to the Office of the Health Ombudsman. People can complain directly to the health service itself. How do those address or not address the kinds of issues that we're talking about here today?
I'll jump in, Simon, just because this is another, I guess, interesting touching point around these accountability measures having teeth. And this is what we always talk about when it comes to large commissions. I mean, if you look at comparably the ACCC, they may not always be effective. They're trying to do a lot in their field, in consumerism, but man, they pull a lot of cases. You know, they are constantly litigating. They are really trying to do something in their field. Do we see that from the NMHC or the QMHC? I don't think so. I think it's all left to, and even if you look at the QMHC website, they leave it to community legal organizations and NGOs and pro bono work. So there is no, as far as I can tell, there is no teeth behind any of these advocacy organizations or funding to really support people to speak up for their rights when push comes to shove, because that's what it comes down to for a lot of people.
Yeah, absolutely. So much of the presentation has been around, you know, preparing so we don't have to use the accountability mechanisms after the harm's occurred. But you highlight there the Mental Health Commission. You know, it's not necessarily their fault. They haven't been given those teeth. Where to your point about the ACCC, so there's a really important conversation that Malik has been having, but wants to continue to have about. We do need an independent regulator of the mental health system that can monitor the performance of the system, monitor the quality of government decision making around human rights, and then can handle and prevent those breaches of human rights where they occur. So I think that's a really important conversation to raise. Julian, did you have anything to add on that? I know you're off mute.
Yeah, in that same vein is like what I was talking about earlier with advocacy, because that's like higher level advocacy and systems advocacy, but I'm also talking about on the ground people who are either wanting to or already engaged with services, whether it be unlock word, unlock word, no matter what it is. At the moment, clinical notes are put in and saying, but there's no measurable way to say this person wants to engage in advocacy. There's nothing to say. There's no data generated. It's just a clinical note of something. So, and it's a physical fundamental impossibility to go through data harvesting through clinical notes. Yeah, but there needs to be some way, whether it be INSIM or some other reporting mechanisms, before people need to engage with the ombudsman. So, it needs to be on the ground as much as it does need to have the processes for the higher level stuff. That's all perfect. The higher level stuff is great and needs to be a foundation, but let's also deal with it on the ground in real time as well, because like I said, at the moment there is no reporting mechanism for a real life event, or a real time event, I should say. It just gets a note put into the patient record and then just disappears off into the ether, never to be heard of again. And that's what I mean by about advocacy, actually, for the patient or communities, as Stephen would say, mentioned before, actually having accountability. It needs to be measured, needs to be having an actual purpose, not just a conversation to appease somebody or to make them feel better for the next half an hour.
Yeah, absolutely. And you know, the Human Rights Act is very much grounded in it's not a mantra. When the Supreme Court held the Victorian government to have breached human rights when it unlawfully detained young people within an adult prison, it said that the government was often treating human rights as mere mantra rather than a practical thing that guided decision making, which, you know, that can happen at a government level, but also at the individual service level as well. It's not mere mantra, it's real measurable outcomes and actions. Does anyone have anything to add to that? Otherwise, I might jump on to our final question before.
Yeah, so
Sorry? Sorry. Yeah.
Just quickly add, I think, we always try to prevent this stuff from becoming political, and then the timing sort of goes out the window with that politics. I think some of this really needs to be tested in court. We need to have those precedences, and I think there's a lot more to be said around vicarious liability. So, the responsibility of these organisations and service providers to provide the right form of care needs to be held to account.
Yeah, and if we weren't going to leave with that message, it wouldn't be an accurate description of the Human Rights Act, which says these are enforceable rights that people have. And so, we listed a couple of examples in that webinar presentation, but there's plenty others that really speak to where people's rights are potentially unlawfully being restricted and breached. What would support better human rights in practice? This is our last question before we jump over to Slido. So what would support better human rights in practice? What should support human rights at a systemic level? So you've kind of got what's individual things that people could do and what's systemic things that their government and services can do. Take half of that question or whole of that question and make it your own. Who wants to jump in? Scott, we haven't heard from you in a while. I reckon you must be rumbling, ready to go.
Yeah, ready to go. Look, we did touch on the Office of Public Advocate, obviously doing that high-level system stuff and working with the various agencies, and both at a local level, but also at a systemic level, the community visitors and how they're working and engaging with individuals. The other one for us, I suppose, from a right advisor point of view, is thinking about the vulnerable and marginalised, and maybe have a limited amount of connection. So, we talk about shining light on particular issues and getting many people involved, and then that within itself can highlight systems issues within the sector. And I'll do a shout out to the Peaks Shine the Light, Eliminate Corrosive Practices. Very worth having a read. I think we've got it in chat as well. And for me, it's and we're sort of touching on it. There's a lot of rhetoric, really positive rhetoric out there. The Act has a lot of words like must do this and must do that, and there's accountability with that. So yeah, having an awareness and expectations of what things need to be met, I think is where you're getting that system level change across the board as well.
Yeah, so it's that mix of the individual day-to-day practice and then those broader systemic changes that we can make. Absolutely, Scott. Anyone want to add? So what can be done at an individual practice level or systemic level?
I would add, Simon, I think just going back to my previous point about what it was like being a clinician in those moments where I, on many occasions, have taken away people's human rights, and it haunts me, frankly. And the things that I've done as a nurse have been haunting. And I think in hindsight, the only thing I can think of on a ground floor level at those moments when those things are happening that would, I don't know, I think it needs to give us pause. If we're in a system that's going to push us to do it, something needs to give us pause. And I think I've mentioned in our previous meeting that something that might have given me pause in those moments when all that pressure is on and everything's happening is, if I have to sign a document or check a box, as silly as this seems, that says, I'm authorizing to take away this specific human right, this specific human right, this specific human right for this reason, and I have to write it out, I'd probably at least think twice. And or engaging in that practice, because it would really bring to the forefront of those moments what's most important. And if I'm reminded in those moments that human rights are most important, and if I'm going to do anything to impede upon those, it needs to be, I can't even think of a reason now, frankly, but there were services will find a reason. Yeah. But I think it will cause more people to turn away from using those practices, I think. But for that to also be effective, people, patients, consumers, family members as well, loved ones and support persons especially, need to know what these human rights are, because otherwise there is no voice to advocate to hold services accountable, because 99 times out of 100, the person or service user is their voice is lost. They don't have a voice for themselves to advocate. They're as I've heard time and time again, the complaints are effectively ignored as and brushed off as some sort of mental illness in a lot of times as well, and that's just devastating. So thank you.
Yeah, and I thank you for, and just want to express my appreciation for you being so open and honest about your practice and your experience of that as well, and how you come to reflect on it now. You highlight something really practical there, and I think it's just a really good example. You talked about a form. Nobody thinks about human rights when whoever designed that form, whatever form it is that you're filling out, did they do a human rights impact assessment when they designed the form? Because if we think that compulsory treatment needs to only be used as a last resort, then the form is a key component in that process. And if the development of that form is likely to create less use of compulsory treatment and identification of less restrictive alternatives, then the better form is the most rights compatible way to make the form. So human rights, there's all these touch points that contribute to the human rights outcomes, but that duty on public entities, or the person, including the person who designs that form, they have to consider, how does this design of this form increase, maintain, or decrease the use of compulsory treatment? How does it increase, neutral, or decrease cultural safety? All of, is this going to, whatever it is, and I think often as policymakers and people working within services, our minds don't turn to that, and part of that's because there's not specialist mental health training about how to apply the Human Rights Act here in Queensland. So that's certainly a gap we see. Anyone else about individual practice or systemic level changes? Otherwise, we might jump to our Slido if there's no burning responses. Now I'm gonna go in order of upticks. So if you're in the Slido and you like some of the questions and you want them to get answered, go in there and express solidarity with an uptick from one of your comrades. So I'm going to go with this first one here, and if we don't get to the questions, we'll it might take a couple of weeks, but we'll send out a written response to answer as best we can some of the questions. So someone's just come up to the leaderboard, but I'll go the one that was just before, which is, how do we get people and systems that know they're violating human rights, so they already know they're violating human rights, to listen and adopt a rights-based approach? Anyone have any thoughts on that?
So can you just clarify, is the question around individual or staff? What was just the direction of it?
Yeah, it's a great point. So it says, how do we get people or systems that know they're violating human rights to listen and adopt a rights-based approach? So maybe they sort of shrug their shoulders a little bit, is my sort of understanding of that question. How do we get them to go like, no, this matters and you need to listen and do something and change what you're doing?
I just quickly, I suppose, I reflect on the rights advisor's role, because that's what I'm here to talk about. And for me, it's around the evidence and collating that evidence and whether there be data. So when I was saying before that there's certain parts of, say, the Mental Health Act where things must happen, and if they're not happening, we would be collecting that information. So it is actually going against the rights of not only the Act, but for individuals as well, and feeding that up the line and saying, well, this actually has to change, and then you escalate through the appropriate channels. So yeah, using that evidence and data where it actually isn't actually occurring.
Yeah, absolutely. And that just goes to an important point there, Scott. If you get access to your own health records, you should be able to see all throughout those records where they have properly considered and complied with your rights when they've chosen to either limit those rights or have made decisions that affect those rights. If you don't see evidence of that, might be worth a complaint to the Queensland Human Rights Commission. Anyone else have a thought in response to that question?
I would add, just as a sorry, I think I was lagging for a minute there. I think I'll just add for a moment around a continued reflection, I guess. I mean, as someone who's practiced breaching human rights and then has turned a new leaf, as it were, really on a ground level, the thing that made a huge difference was my lived experience, but also the lived experience of other people. So often is the person, the service user, patient. You know, we're othering people all the time. Notice we're not just calling them people a lot of the time in services. It's service user, consumer, patient. You know, that person with mental illness, whatever it might be, and that othering distances us, and that enables violations of human rights on a personal level. The thing that really changed for me was when I really opened my eyes and ears to the stories, not the data necessarily, although that might help, but the stories of people and their experience and the harm that those experiences have endured and continue in their lives. That's what's made the biggest difference to me on a personal kind of clinical level. Aside from that, I guess true accountability. Like I said earlier, has anyone ever been litigated against for breaches of human rights in mental health systems? Probably, I've not heard of it. I mean, Simon, you might know. I've not heard
of a few
of
cases, but it's pretty rare. It's pretty rare.
Pretty rare, right? And so there's no concern by the services. On a service level, they're not worried. Why would they be? What's the repercussions?
Yeah. And your contrast with the ACCC is an important one there as well. Every system, every person works under time constraints, and that's not to minimize them, but how people make sense of those circumstances is based on priorities, and people's priorities are shaped by incentives, and having accountability mechanisms that make rights matter. It sounds like it's a kind of crucial component of that. If there's nothing else on that, I want to give someone else a crack at one of the other questions. So we've got to the point of measurements. Are there good models or examples of how human rights are developed and impacted, and impact assessments done re human rights in this space? I might open that up to the audience, to the panelists, if they've come across any. I certainly have, but I'll wait to hear from the panelists. Yeah.
I can't say I have a lot of experience in that particular realm, but things I've been reading for a while and stuff like that from other countries who have gone through these processes, and like Canada and the UK, who are more further down the road with this type of stuff than what we are. Even Scotland, for that matter, they have some great stuff. I haven't read it in detail, but they are certainly going in the right direction. And I think we without having to sort of reinvent the wheel, but we could also do something of our own as well, because we have cultural significant differences, whether it be First Nations or coloured or whatever it is. So we can't just take a cookie cutter thing, but we could take certain components from those countries that are ahead of us and make a foundation for that type of thing.
Absolutely, Julian, and I'm sure someone in the chat. My phone is firing off with Teams updates, so I know people are hitting it pretty hard in there. But Trieste is a great model for a system that's to the point that you've made, Julian, and then Ayden made earlier. They just decided one day, there's a great history of it. I'd go read it if you haven't. They decided that we don't want to do this anymore, and we don't want to have these coercive systems anymore. And now I don't think seclusion events really occur there at all, and the rates of involuntary treatment are very small, and very rare and exceptional circumstances.
Simon, just to the question, sorry, before you jump in, Scott, so I'm so sorry. Just because the question does specifically mention measurements and impact assessment, and I know that the World Health Organization's quality rights toolkit framework, being heavily spruiked internationally, I don't think we've done too much with it in Australia. But it is a relatively well-designed framework that I was looking to do a project with, but lost had other detoured a bit, but it does look pretty good. It's basically an assessment of systems framework. So you go into systems, go into a service, and you conduct an assessment using quality.
I think Ayden got whatever I got earlier. Oh, sorry, we lost you for the last 15 seconds, Ayden. We said we've got, and then you left us on the edge of our seats. Yeah. Can you hear? Can you?
No,
yeah, okay. We didn't get the last 15 seconds, but yeah, certainly the World Health Organization's, yeah, I'm across that framework too, not in detail like you. So that's a great resource, and I'm sure someone will put that in the chat. Scott, did you have anything to add on that?
Yeah, I was just because I'd seen some of the work of the hospital health services doing the human rights impact assessments, and I was trying to hunt them down. I couldn't find it, and I wasn't successful. But I did stumble across Department of Education. They've got a decision making sort of matrix that you can work through. So if you're looking for them, there's some of them that are about. Yeah, so that was one I stumbled across. Went, oh, actually, that looks pretty good.
Yeah, definitely. There's some and I know there's a Queensland Government procurement guide as well around human rights too. So yeah, there's a range of really helpful guides there as well. One that I'll just add to answer that question is I've put in the chat. I'm a Queenslander originally, but I briefly transplanted down to Victoria, and during that time I worked on some of those Royal Commission mental health reforms, and a few of them fell over, but one of the good ones that got up was an outcomes and performance framework. So what do you want the system to do, and how do you measure whether it's doing it? That was really grounded in the Charter, which is the same as the Human Rights Act here. So all the measures that are created there are really conscious of improving human rights and not adding to any current limitations on human rights, and in fact reducing the current limitations and breaches of human rights. I might, I can see there's one here around work health and safety. I'm going to jump to that one. So it says work health and safety and psychosocial hazards and injury, and where potential breaches of human rights are seen and reported by workers, and what is considered reasonable management. Actually, there's a fair bit in that. So I guess what I'll do is I'll reframe that in a general sense of where. Does anyone on the panel have thoughts about how work health and safety or psychosocial safety, including for lived experience workers, might intersect with human rights?
Yeah, I'll straight up and say, we peer work and everything like that, but we also need to make sure supervision is embedded, and there's a proper framework for supervision. So, what I mean by that is for our debriefings and coordination of things. So so people just don't get left by the wayside, or you don't get overwhelmed by your workplace. Whether it be vicarious traumas or whatever else. So I think supervision it could probably fit really neatly in between the WHS stuff and human rights, because by taking care of the peer workers or other people like that, or nurses or anything, or doctors for that matter, or any clinical people for that matter, you have better patient outcomes, better results for everybody. So I think supervision, a real robust supervision structure would be absolutely amazing, because at the moment it's there, but it's so spreadly thin, or it's difficult to access.
Yeah, absolutely, Julian. And so for peer workers, just picking up on your point around that, it's people have a right to an equal standard of work conditions. And if you're getting a worse experience of the workplace as a peer worker because you have mental health issues, then there might be an equality issue there in the workplace, just as if you were getting a worse experience because you were trans or, because you're a First Nations person. So it applies to workers, and you kind of highlight that it's not zero sum better experiences, hopefully raises all ships there as well. Anyone else on that one? It's a specific one. Anyone have any thoughts?
Yeah, it's about like I'm not entirely sure how it intersects with the Queensland Human Rights Act, but certainly human rights generally, it's about how I think of rights normally in terms of access, entitlements, and representation. So we want to be ensuring that everyone has access to the right care. And in terms of entitlements, it's who's making the decisions for us. So there also needs to be a choice around where individuals might like to get their healthcare from. And in terms of representation, what are the mechanisms for injured workers to put forward their concerns or their complaints? What are the mechanisms for appeal on decision making or appeal on assessments as well? So, but generally, access, entitlements, and representation.
Yeah, absolutely, Stephen, and I think that's a good summary of the kinds of entitlements that people have in this space. And the other thing I would add is that the Human Rights Act, it doesn't affect federal laws, so Fair Work, that's its own thing. But when it comes to state work health and safety laws, if somebody came to court or to work safe or safe work, it's different in every state. They need to the safe work would need to properly consider and comply with human rights in any decision it makes. And if it came to court and they were interpreting the Work Health and Safety Act, the court would need to interpret the Work Health and Safety Act in the way that most upholds people's human rights as well. So it shapes how other laws are interpreted. I might make a captain's call and do a last question, and I'm going to jump down a little bit to one which is that says, how can a human rights approach ensure that culturally and linguistically diverse voices are not just consulted, but meaningfully included in mental health system design and decision making? So how can human rights laws or human rights in general help us advance those outcomes? So it's a meaningful inclusion in system design and decision making.
I was hoping you'd go down to that one, Simon. I sort of saw that one as a bit of a priority for myself. So I think I mentioned before the specialist mental health expert groups, maybe not. Within the chief psychiatrist policy reviews that they're constantly doing, there's like 30 of them, and they're always looking for membership to attend that, to provide that input. So not only from a culturally and racially marginalised, but for me it's also First Nations as well, having them at the table, talking around the issues that are being seen, and feeding into that as well. And then from a rights advisor point of view, it's around the translation and interpreter services, and ensuring that is becoming a common practice that's occurring as expected under the Act as well.
Yes, yeah, absolutely, and the whole range of actions that could be taken there, Scott. And building on that, that the inclusion or meaningful inclusion, maybe, of culturally and linguistically diverse folks in decision making is not just an expression of inclusion. It's a right under, if you don't include culturally and linguistically diverse communities in those decisions, you're going to get a lower standard of mental health care for those communities than you would because the services aren't suited to their needs. So again, that's the crucial importance for government to think early. Oh, we need to get the right voices in the room, because if we don't, then we might be breaching rights later. In this case, equality or cultural rights for CALD communities. Anyone else on that?
I'd put forward that it's not just about consulting the CALD communities or First Nations communities. it's about working with them. That I always like to approach these things as a partnership. And I think, when we have data, we will validate that data by checking it with a number of reference points. And we can do that when we're working with minority communities as well, by establishing communities of practice where we invite the recognised experts in the community. And I think that's one thing where we could improve, is being able to identify who the experts are in the community and ensuring that they're around these tables. We're able to cross-reference, cross-check, and improve as we move forward.
Yeah, and it's a great point, Stephen. And a term someone's gave me years ago was to conceive of it as thinking partners, which means that you're thinking and decision-making partners from the very beginning of the process, rather than you're 3/4 or 4/5 down the way of your decision-making, then consult with communities. And so I think that certainly resonates. Are there any? I'm going to get final words from anyone. Otherwise, I'll move us to wrap up in a second. All right, I reckon we're at time. So thank you everyone for coming today. We hope you got some value out of this seminar. What we'll be doing is we'll be sending around a whole bunch of resources in the next couple of weeks. We might stagger them a little bit, so we have the presentations and the panelist conversation, and if we haven't got to your questions, we'll try to get back to you with a sort of Q&A response there as well. Thank you for all of the panelists, to Eloise and to Stephanie earlier as well. And we hope that you keep human rights in mind, as you progress through the rest of Mental Health Week and your work going forward. Thanks again. Bye.
Thank you, everyone.
Thank you, everyone.